Hello, everybody. Oh, this is the wrong number. Good evening, everyone. Are you able to hear me?
Yes.
Yes, sir.
Hi,
Yes, sir.
I am on this. Yeah, we'll just refresh some basic stuff so that last classes or last discussions, whatever the basic stuff to start. Even if a person starts off new today, it would be useful for him. So we have already revised, or let's say we have already revisited on the indications of neuromonitoring. How does TCD play an important part, and how important is non-invasive monitoring in the tired neuromonitoring algorithm, and to decide on escalation or de-escalation or intervention needed. So just to start off with the basics of TCD, there are five windows, essentially four commonly used windows: transorbital, transtemporal, submandibular, suboccipital, and very occasionally or very rarely, which is utilized, is the frontal window. So the most commonly used window is a transtemporal window. If we shine, or if we put the skull or the broken skull across the sunlight, this is the temporal bone is where the squamous part of the temporal bone is where the thinnest part of the bone is. So this is taken as an opportunity to insonate the intracranial structures and the vessels. So amongst the transtemporal windows, the most commonly utilized view for the vasculature is is the mesencephalic view, where we identify the midbrain or the butterfly, as it's commonly addressed to as. And the second view, as we tilt the probe upwards, is the diencephalic view, where we do visualize the deep nuclei along with some parts of the ventricles. And on further angulation of the probe, we go into what's called as a ventricular diencephalic ventricular view, where we do see the deep nuclei along with the lateral ventricles. So this is what we were speaking as the mesencephalic view. Here we can see the one second. Here we can see the midbrain, the butterfly, what we call as, and just anterior to the midbrain, we can see this hyperechoic fluff, which is the suprasellar cistern, where all the vessels or the circle of Willis lies. And with respect to the visualization of the vessels, this is how the vessels are visualized on transtemporal window. either it's ipsilateral or contralateral. Most commonly insonated windows are, the most commonly insonated vessels are the MCAs, ACAs, PCA, ICA on the transtemporal window. This is again the next angulated view, that is the diencephalic view, where we can see some parts, the frontal horns of the ventricles, along with the thalamus and other deep nuclei, and also the pineal gland. On further angulation, we can even see the lateral ventricles, the bodies, and the corona radiata. This is the ventricular view of the transtemporal window. This is again the landmarks to identify the mesencephalic view. Here we can see the hyperechoic falx cerebri and the hyperechoic sphenoid bone, which are the main landmarks to identify the windows. And the midbrain, which is commonly called as the butterfly-shaped midbrain, is another landmark posteriorly. And here, just anterior to the midbrain, is here where we see the circle of Willis. The next view is the suboccipital view, where the window is in the suboccipital area, and where we go, when we put the skull across the sunlight, we see that there is translucency, which is taken as an opportunity to get this view, which is called a suboccipital view. The probe is directed in such a way that it is angulated towards the root of the nose, or the nasion. So this is how the suboccipital view is insonated, and the vessels which are visualized in the suboccipital view, mainly the vertebral arteries, the picas, the basilar artery. These are our main targets of insonation in the suboccipital view. This again, the same thing, vertebral arteries are visualized at the depth of 4 to 8 centimeters or 40 to 80 millimeters, and basilar arteries are always visualized beyond 80 millimeters. So this is one of the images of the suboccipital view, where we can see this is the foramen magnum, and here we can see the two vertebrals joining and to form a basilar artery at approximately 8 centimeters. Here we can correlate this. Beyond this is the basilar artery. This is again the same structure, where we can see this anterspinal and the picas getting shooted off from the ipsilateral and from the vertebrals. So again, another rare or very rarely or a very occasionally used view is the transorbital view, which is not a part of the basic complete insonation. The thing which we need to remember, as we had already discussed in the previous session, is that it is most susceptible to the mechanical injury and the thermal injury. So the power and the MITI needs to be kept in mind. And what are the vessels which we are insonating through this window? It is the ophthalmic artery and the carotid siphon. So this is how the ophthalmic artery, it's somewhere between 4 to 6 centimeters is the ophthalmic artery insonated, and beyond 6 centimeters is the carotids insonated. This is again the same thing. The intraconal structures, the intraconal vessel will be the ophthalmic artery, and the extraconal or beyond the cone would be our carotid siphon. And this is how the visualization takes place. Another view, the fourth view, being the submandibular view, which is of importance, especially when we are calculating our indices such as Lindegaard ratios and other Sloan's ratio. There are various indices. So this is of importance to differentiate the ECA, the waveforms, and the ICA waveforms. This is how we insonate. And this is to differentiate between the ICA and the ECA. So here on the left-hand side of the screen, we can see the ECA being insonated, which is extracranial in nature, and hence it is a high resistive waveform. Whereas on the right-hand side of the screen, it is the ICA, which is getting the internal carotid, which is getting insonated, which is a low resistance waveform, and both are away from the probe because both are entering the intracranial compartments, and they will be moving away from the probe. Hence, they are blue in color, and the main characteristic differentiating point between these two is the pattern of the resistance which we obtain in the each waveforms, which we will be discussing it further. This is again to differentiate, how do we differentiate ICA and the ECA on the submandibular view. ICA, as we all know, has no cervical branches, so there will be no ramifications, whereas the ECA has plenty of ramifications. And ICA has low pulsatility, whereas ECA has high pulsatility, as we saw there. And to tapping, or let's say to any external manipulations, there are no changes in the ICA waveform, whereas we do find changes to tapping on the external carotid waveforms. And the ICA waveforms to be defined using a pulse wave Doppler, they are typically low resistive waveforms. There are circumstances where the ICA can get externalized or the ECA can get internalized, but to define it classically, it's a low resistance waveform in contrast to the ECA, which is a high resistive waveform. And ICA has a high diastolic component, or the robust diastole, which is a part of the low resistive waveform, and a low systolic component. Whereas in contrast, ECA has a low diastolic component and the high systolic component. Again, going back to this picture, here we see ECA has a high systolic, whereas ICA has a low systolic, and ECA has a low diastolic, whereas ICA has a high diastolic. Again, the pulsatility index, we will go into the intricacies of it further. So this is again one of the rarer views which are utilized, the frontal view, where we insonate across the supraorbital area. The main aim of this is to insonate the ACA and the other structures. So here we can see the contrast, the difference between the transtemporal A2 and the frontal A2 is that the transtemporal A2 is blue, that is moving away from the probe, that is the ipsilateral one, whereas on the frontal view, the A2 is coming towards the probe. Hence, the vessel which is visualized here is the A2, which is coming towards the probe. This was again the same thing, the frontal view. The typical area of insonation is on the supraorbital ridge, sliding between somewhere in the circular diameter of 3 to 4 centimeters. So the other thing is, to conclude this introduction, it is the representation of all the temporal windows and the arterial depths at which it is visualized. So the MCA is typically visualized between 30 to 60 or 60, 65 millimeters. And A1 is 60 to 75, and which is going away from the probe. A2 is, again towards, and PCA P1 is toward, which is red. P2 is away. Both are visualized posteriorly at the depth of 60 to 70 millimeters. And suboccipital, the basilar artery is typically visualized beyond 80 to 120, beyond 8 centimeters, whereas vertebrals are visualized somewhere between 60 to 80 millimeters, that is 6 to 8 centimeters. And the ophthalmic arteries on the transorbital windows are coming towards the probe, and it is visualized somewhere between 4 to 6 centimeters. And the typical velocities of all the vessels have been depicted here. So the main point which we need to remember is, if we are lost in any of the windows, we need to come back to the reference point. The reference point being the midbrain in the transtemporal window, the foramen magnum in the transforaminal window, the eyeball and the optic nerve, which is visualized in the transorbital window, the mandible in the submandibular window, the carotid artery shadow. The most easiest thing to pick up is the carotid artery. Hence, that is the landmark which we need to return back. And on the frontal window, that is the third ventricles and the frontal horns of the lateral ventricles forms the reference point. So this was again one of the insonations where typically we see this is the MCA dividing it as superior and inferior divisions of M2, and this is the P1 and this is the P2 wounding around the midbrain. This is again blue is the A1, which is going away from the probe, whereas this red beyond 7 millimeters is the contralateral A1, and the blue on the opposite beyond 8 centimeters is the contralateral MCA, which is visualized. So one of you can unmute, and if at all feasible, if at all it's okay, A, B, C, D, E, F, G, if at all any one of you can name it, or
Ipsilateral ICA, ipsilateral ACA,
A is
ipsilateral MCA,
FCA, yeah. B is,
ipsilateral ACA.
yeah. C is,
C is contralateral MCA.
it's not MCA, it's just at 7 millimeters. If it's, yeah,
ICA.
it could, ICA would be again, it can either be blue or, I mean, it can be coming towards or going away depending on the angulation. Probably it is, C is contralateral A1.
Okay.
Yeah. D is,
P is P1, P1 uh, ipsilateral P1.
it is blue.
Blue. Ipsilateral P2.
Ipsilateral P2, yeah. Then
Uh, then
E
we see
is
D.
F, you can name it.
F is ipsilateral P1. No.
Ipsilateral P1, yeah. G is
Contralateral P1. No.
contralateral P1. D is a red signal, which is much more posterior, or let's say it is typically or exactly at right angles to the MCA. What is this
Okay.
E? What is this E? Anyone knows how to remove this line which has been put up? I don't know.
ICA. ICA.
No, how can you see ICA in transtemporal? This is a transtemporal window, right?
Okay.
So there can be occasionally red Doppler signals coming towards the probe on the transtemporal window, but it is much more posterior or let's say it's at right angles to the MCA. This is typically these are the posterior choroidal vessels, which are typically the branches of the PCAs. So this we need to remember, and this we shouldn't confuse with the uh, or the MCA when we insonate. So hence the pointer direction and identification of the landmarks, because this is MCA because it's running along the sphenoid edge, which goes into the Sylvian fissure. So this is not running in the similar way. It's running somewhere posterior, and it is arising probably from this. I have a video further. So these are always posterior choroidal arteries which are arising from the P1. So these are not to be mistaken with your MCAs. So this is again one of the insonations where we could see the entire circle of Willis in one transtemporal insonation. So we could see here, this is what I was talking about. There is a red offshoot which is getting off from the P2 part. This is probably some of the posterior choroidal vessels, which for a naive or a novice observer can be mistaken for posterior choroidal arteries. So with this background knowledge of the vasculature, the depth, the windows, and identification of the various vessels, we get into what is called a spectral trace. What is a spectral trace? So we do know that inside the blood vessel, the reflection is caused by the traveling RBCs. So hence all the RBCs moving in the vessel are not moving at the same speed. So what is a spectral trace? It is the velocity of the spectrum of particles moving at various speeds. So quite naturally, the velocity of the particles moving at the center has the highest velocity, whereas in the periphery, it is the lowest. So not all points, as I told, inside the vessels are moving at a constant speed. Hence, this is what is represented in a trace. This is what is called as a spectral waveform, because our gating window is as wide as 5 to 10 mm. So our spectral waveforms are the velocity representation at as big as 1 centimeters or 5 millimeters. So our the spectral waveform depends on our gating window. So the guidelines suggest that our gating window should be typically 5 to 10 millimeters. And tracing of the intracranial vessels, as we already saw in the submandibular window, differs from the extracranial vessels in the various aspects, and intracranial vessels are typically low resistance waveforms. And this is the spectrum of the changes in the vessel patterns or the spectral waveform patterns as we go from the uh, arch of aorta to the carotids, to the common carotids, to the internal carotids, to the cerebral waveforms. So as we can see here, the aorta has a very high resistance waveform, and there can be occasional reversal in the diastole also. Whereas in the common carotid, it's more predominantly above the baseline, and it is still high resistive waveform. Carotid bulb typically has a low resistance waveform. That's where it starts off, and it is more accentuated in the ICA and the MCA. This is again in the posterior circulation. The V1, which is the extracranial part, has typically a very high resistive pattern, whereas V3 and V4, which are the intracranial parts, have a low resistive, low PI waveform patterns. This is the spectrum of the changes in the spectral waveforms as we move from the extracranial to the intracranial vasculature. So this is again the spectral tracing of the two types of insonation. Can someone identify what is on the left hand side and what is on the right hand side with typically with respect to the spectral waveform tracing? What difference do we see here? So as we can see on the left hand side of the screen, there is a wave spectral tracing, and on the right hand side there is spectral tracing. Which is normal, which is abnormal at least?
Right hand side is abnormal, sir.
Yeah, why do you feel right hand side is abnormal?
Uh, High peak systolic velocity along with that spectral waveforms is not seen properly.
Spectral waveforms are seen properly. Can you see my pointer? Right pointer?
Yes, sir.
This one? Yeah. So as we can see here, the velocities on the right hand side of the figure is the peak velocities are 2 and 4, whereas on the left hand side it is 125. So here if you see at the base, there is some sort of a turbulence here. With each spectral or with each beat, there is some sort of a noise which we can see in the initial half of, or let's say initial one third. Possibly it is just at the systole. So this is, whereas that disturbance is not there in the left hand side of the figure. So this is what I was talking of. So this is a typical laminar flow or a smooth flow, whereas on the right side it is a turbulent flow, because it could be possibly because of hyperemia, or it could be because of a possible stenotic lesion. So this is what we call as a ultrasonographic murmur. So if we can see a noise in the initial half to a third of the uh, beat of the spectral waveform, this is possibly a narrowing or a flow-induced stenofocal stenotic lesions. So this is again the same thing on the non-imaging Doppler. As we can see here at the base, there is nothing here. This is a laminar flow on the upper part, whereas on the bottom part, there is some noise or a disturbance which is present, which is the turbulence, which is possibly a stenotic lesion which we are insonating. So with this knowledge, we get into how do we identify the waveform patterns, or what are the steps to identify the different waveforms. So the step one being, we need to identify which is the beginning and the end of cardiac cycle. Step two is determining the sharpness of the upstroke, the diastolic step down, and the adequacy of the diastolic velocities, and also to check for the transition and check for the symmetry. And the third and the final step being, we need to synthesize an information and come to a conclusion and explain the waveforms. This is the most important part. And also simultaneously, we need to identify what are the technical errors, what are the system, whether the waveforms are a reflection of a systemic alteration or a local alteration, or what is the status of the intracranial pressure. So the step one being identification of the systole and identification of the diastole, or let's say when we put it across, when we put it in conjunction with the ECG tracing, we can see that the systole lasts for 1/3 and diastole lasts for 2/3, and this is how the tracing reflects. We can see P1, P2, and the dicrotic notch, the P3 follows. So post dicrotic notch, when we are diastole follows. Step two is identification of the, or let's say, how do we identify which is systole and which is diastole, is through the waveforms. That is, initial 1/3 is a systole, whereas the latter 2/3 is a diastole. And in the step two, we identify how is the rise, because we all know the brain has no glycogen stores. The blood which is going into the brain is always taken up rapidly. Hence, there is a rapid upstroke. So this is a normal waveform tracing. We are insonating the ipsilateral MCA here. There is a rapid upstroke, which is reflected in the rapid rise up to the P1. That is the part of systole. And there is a stepwise deceleration. There is not a rapid deceleration. There is a stepwise deceleration. And at no point in the diastole or in the decelerating process, we don't see any variable humps. We just see a gradual step down reduction. And if you see here, the peak systolic velocity somewhere corresponds to 90 centimeters per second. And if you see at the diastolic velocity, it somewhere corresponds to 40 centimeters per second. So this patient is having a peak systolic velocity of 90 and a diastolic velocity of 40. So this is a robust diastole. Any diastolic velocity beyond 1/3 to a half is considered normal, and it is called as a robust diastole. So the components or the steps of identification of, or let's say step two of identification of a normal waveform or an abnormal waveform, is a patient should have a rapid upstroke. There should be a stepwise deceleration. There should not be again a more vigorous fluctuations in the stepwise deceleration, and there should be a robust diastole. Robust diastole meaning the velocity should be at least half to 1/3 of the systolic velocity. This was the same thing again I was telling. The intracranial vessels are low resistive waveforms. This is what is reflected here, and 1/3 is systole and 2/3 are diastole. So there should be a rapid upstroke, stepwise deceleration. No point of an adder is below the end diastolic velocity. I would show some images where there is some point in the decelerating path where there is an adder below the EDV, and there should be a diastole, a robust diastole, that is 1/3 to half of the systolic velocity. If these four components are present, this is considered as a normal normal spectral waveform tracing of a intracranial Doppler. So this is how we approach, this completes our step two. So step three is identification and analysis of the waveforms, which are obtained through the spectral tracing. There are three velocities which are most commonly, or which are more important for us. That is the peak systolic velocity, the end diastolic velocity, or what's called as a mean flow velocity. So the formulas being the same, and there are two indices which we need to remember: the pulsatility index and the resistive index. So the PI is the peak systolic velocity minus the end diastolic velocity divided by mean flow velocity, the normal values being 0.8 to 1.2, whereas the resistive index is the PSV minus EDV divided by peak systolic velocity. So the PI has gone in more with the transcranial Dopplers. The resistive index is not much utilized in the transcranial Doppler literature. So these are the normal velocities depending on the age and depending on the different vessels and the depth of insonation. So these are the vessels which one has to insonate in what we call as a complete basic insonation. So the norm is MCA velocity should be greater than ACA, should be greater than PCA, should be greater than vertebral and basilar, should be greater than, last but not the least, the internal carotid artery, the ICA. So in a busy practice, while we are doing a quick TCDs, if this is the order which is maintained, probably we don't need to mind much. If at all this order is broken, that's when we need to sort of think of some pathology which is present. So step 3.1 was in that stepwise approach was, we go to step 3.1 with this example. An awake patient while insonating at 60 to 65 mm, identify the vessels and comment about the spectral Doppler. Can someone do this?
So contralateral A1 segment.
Why do you say it as contralateral A1?
ಏನು
I am insonating somewhere. I think probably it
ಅದೇ
was not
ಹೋಗಿಲ್ಲ
visible.
ಮತ್ತೆ ಏನ ನೀ ಅಲ್ಲೇ
60
ಖಾಲಿ ಏನೇ ಇರಲಿಲ್ಲ ಪೇಷಂಟ್ ಇರಲಿಲ್ಲ ಬರ್ತೇನೆ
60 to 70. I am just insonating at 60 to 70.
ಬರ್ತೇನೆ ನಂದಿನ ಬಾ ಅಲ್ಲಿ
This is ipsilateral MCA, which I am insonating, probably proximal and distal. What are the things which we do see here? This hyperechoic, sort of vibrations which we see.
turbulence.
Not turbulence per se. Turbulence would not start off in diastole. That's where the main reason. Here we can see the upstroke, right?
Microthrombi?
Not microthrombi. This could probably be a microthrombi. This which we. Okay. Are you able to see my pointer, red pointer?
Yes, sir. Yes, sir.
Yeah. This could be microthrombi. What is this? See, this is not turbulence because the turbulence would be highest in the systolic part. So here we can see this is a waveform which is rising. In the systole, it is free of turbulence. I mean, the systole, it's free of such a aberration. What could it be?
Line consultant.
So this is when the patient was speaking, okay? So he was intermittently, he was trying to communicate something. That was the reason why I put an awake patient. So he was speaking. So this is how, so the step 3.1 in that figure or in the steps of identification, we saw that we need to identify what are the artifact, what are the real turbulence. So this was the reason why I put up this slide. We need to identify what is a turbulence and what is a aberration or an artifact. Okay. So identify and the error and an artifact is step 3.1. So what is blood flow versus velocity? We are interested in blood flow. Flow is nothing but volume per minute, whereas velocity is nothing but centimeters traversed in a second. Since we are measuring in the larger vessels, we do assume that there are no major changes in the diameters happening. And hence, any increasing velocities, we correlate, or let's say we conclude that there are increasing in flows, because most of the vessels which we are insonating are just conduit vessels. So increase in the velocities equals increase in the flows for transcranial Doppler purposes. So what are the reasons for increasing velocities? Either it has to be spasm or stenosis or increased flows, which is nothing but hyperemia. What are the causes for reduced velocities? Again, very severe stenosis. Here it is just stenosis and spasm. If at all the stenosis and spasm is very severe, there could be reduced velocities. And in the post-stenotic phase, again, the velocities could be reduced. And also, if at all there is systemic hypotension, it can also lead to reduced velocities. So to identify or to, let's say, to define the velocity in correlation with the blood flows, this is one such curve, what's called as a Spencer-Reid curve, which all of us doing transcranial Doppler have to remember. So this is a graph of a lumen diameter, blood flow, and the velocities. So as the lumen diameter reduces, we can see here 20, 30, 40, 60, 80, 90, and 0. This is complete obstruction. So up to 60, the blood flow and the velocities are relatively maintained. So we would have seen on the carotid Doppler reports, grade 1, grade 2 is still acceptable. So grade 2 is when the blood flow starts reducing and the velocities start increasing. So grade 3, the velocities would be highest and the blood force would have gone down significantly. Grade 4 and 5 is where the blood flow is so drastically reduced and the velocities also reduces. This is what I was telling. When there is just a mild stenosis or a spasm, the velocities are increased. Whereas if the stenosis is beyond severe, grade 4 and 5, that is beyond 90%, the velocities also reduce. So this is what is called as a Spencer-Reid curve. This is again the representation of a Spencer-Reid curve in the form of in comparison with the transcranial Doppler waveforms. When the velocities or when the diameter is reduced up to a 50%, the normal transcranial Doppler waveforms are maintained. Whereas once it starts dipping below the 60% mark, here we see increasing velocities and there is some turbulence which you see here. So this is what the turbulence looks like. So whereas beyond 90%, the velocity is reduced and it is a very, we don't see this four normal components. That is, there is no rapid upstroke, neither there is no stepwise deceleration, and the diastole also is not very robust for that matter. So once we know about the velocities, we need to know what is a flow acceleration. Flow acceleration is the rate at which the velocities increase during the systole, or let's say the rate at which the peak velocity is reached. High flow acceleration, it is normal. That is what is called as a rapid upstroke. And high flow acceleration is also seen in stenosis because between 60 to 80%, there is increased velocities and the rapid upstroke is maintained. Whereas low flow acceleration states of TCDs, or the waveform what we call as the parvus et tardus, which we would have done read in our clinics as slow rising and late peaking waveforms. Parvus and et tardus. That's what it is seen in severe proximal stenosis. It is seen in aortic stenosis and also in poor cardiac functions, which lead to this parvus et tardus pattern. So two things which you need to remember is the velocity variations and the flow acceleration variations. So this is again to represent how does the flow acceleration and the normal flow acceleration looks like. The image on the right should depicts a normal flow acceleration and the normal velocities and a normal waveform with a robust diastole. Whereas the picture on the left, we see that the rapid upstroke is missing, and here we can see this star is much more beyond the rapid upstroke, or let's say it is much later into the systole. That's what is called as a parvus et tardus pattern. Here again, it is the same MCA which we are insonating. This was a patient of distal M1 occlusion. I've insonated the proximal M1, which looks normal, whereas the distal M1, where it is getting bifurcated, which I insonated, showed the parvus et tardus pattern, where there was some residual stenosis, which depicted this. The velocity has not risen, and there is a low flow acceleration state, and it is more of a low PI waveform. So this is again one of the image where we could see the parvus et tardus. This is which window is this? Anyone? With the help of a reference, which window this could be? This is the foramen magnum. Okay, this is the suboccipital window. Here the vertebrals are coming and joining, and at 6 centimeters it's giving rise to basilar. Here the two reds which we can see is possibly the shoots of pica or antispinal vessels. So here we can see that the basilar artery which I'm insonating doesn't have a rapid upstroke. It is a slow rising, late peaking type, low pulsatility index, and doesn't have a good systolic velocity, or there is no rapid upstroke. This is again one of the examples of a parvus et tardus waveform. So once we identify the waveforms, once we identify the artifacts, and once we identify the velocities and the flow acceleration, we need to differentiate whether the waveform which we are looking at, is it due to a local issue or is it due to a systemic issue? Because both local and systemic hemodynamic effects can have an impact on the TCD waveforms. As we know that systemic conditions are always bilateral and includes both posterior and anterior circulation. This is one of the clues which we can sort of derive to differentiate whether it's a systemic issue, let's say a patient with a severe aortic stenosis will have a high resistive waveforms both in the anterior and the posterior circulation. Whereas in the focal anterocirculation stenosis, the high resistive waveforms are limited to the anterior circulations alone. The posterior circulations would be spared. Hence, to conclude whether it's systemic or a local issue, we should always perform a thorough window shopping, like how we do even otherwise in our daily routine before we buy into the product. So before we conclude, we need to do a thorough examination of all the windows, and we need to write down the velocities and the PIs of all the vessels which we insonate. So that's when we can differentiate whether it's a local issue or a systemic issue. So coming to the localization, if at all, if the localization is low, if we conclude it is a local, the lesion is either proximal to insonation or distal to insonation, or we are insonating at the site of the lesion, or it could be a combination of these things, which is called as a tandem lesions, where stenotic lesions can be present both proximally and distal to the site of insonation. If at all the lesion is at the site of insonation, so here I am insonating at 5 centimeters. So if at all the lesion, if this is the waveform, if at all the lesion, or let's say lesion, I mean by saying any nature of lesion, what are the waveforms which we obtain? It can be variable pattern. There can be either increase or the reduced velocities. There could be possible bruise, and there could be asymmetric flow profile compared to the contralateral side. So hence, always comparing to the opposite side is essential to sort of differentiate between an ipsilateral problem or a contralateral or a diffuse problem. So can one of you tell what is the problem here? So I have already put it up that lesion is at the site of insonation looking at this waveform. That's what the conclusion we can arrive at. So in the interest of time, I will just run through this. So here, as we see here, through each cardiac cycle, we can see this bruit. So there is a possible stenosis, or there is a possible atherosclerotic plaque, or there is a spasm, whatever it is. There is some focal narrowing at the site of insonation. This, and hence, so we don't expect velocities of 150 centimeters. So there is stenosis in the range of, can anyone tell what could be the possible range? Because the velocities, the peak systolic velocity is 150, and the diastolic velocity is somewhere 65 from this figure, and we can see an arterial bruit, or let's say a sonographic murmur here. So what could be the possible range of stenosis from the Spencer rate curve?
80%.
Yeah, 60 to 80% probably. Okay, so in the range of 60 to 80%. One sec, I'm just trying to. Yeah. So again, this is another picture which is showing insonation at the site. What we can see here? Here we can see reds, blues, reds. Here, whereas there is a mixture of lesion, right? I mean, there is a mixture of colors. So there is a aliasing, correct? So when we insonated here, so here we are insonating somewhere at the depth of 8 centimeters. This is a suboccipital window. This is the foramen magnum. So when we are insonating at the depth of 8 centimeters, we see that the velocities have reached to 150, and there is again some bruit present. So this indicates that the velocities can be variable. So this was again the transcranial Doppler image, let's say, sorry, DSA image of that patient, which showed that there was a basilar artery thrombus. So this was again the lateral shoot of the basilar artery, which was very well seen in this figure. So here at 8 centimeters, here again in the transcranial, in the DSA image, this patient eventually underwent mechanical thrombectomy just before that it was. So here we can see this. There is one sec pointer. Here there is a stenosis. It's secondary to a thrombus, which is down in the proximal portion of the basilar artery. So again, we did identify what could be the changes in the pattern if the insonation is at the lesion. So what are the changes we expect if the lesions are proximal to the insonation? So if the lesions are proximal to the insonation, that means that we are insonating at one part, whereas the, let's say, a stenosis or a thrombus is proximal or towards the heart of that area. So what we get is reduced flow acceleration. That is the parvus ectardus pattern, or there could be a post-stenotic dilatation, which is reflected as low pulsatility index, and there could be possible recruitment of collaterals. Collaterals again is a whole new, uh, you know, uh, spectrum of utilize the advantage of using transcranial Doppler to detect collaterals. So this is again the same thing. Here I am insonating at the level. This is the ICA which I am insonating. This patient on a carotid Doppler had complete occlusion, whereas we can see that there is a parvus ectardus, the slow rising late peaking pattern, and also low flow velocities with typically low pulsatility index. This is what we get when there is a lesion proximal to the insonation, because the lesion was already in the neck. So what are the patterns which we get if the lesion is distal to the site of insonation? Here we typically get what is called as a high resistance waveforms. Here we see there is a rapid upstroke which is maintained, but there is no stepwise deceleration. There is a rapid deceleration and the end diastolic velocities are way too less. So in insonation where there are lesions are distal to the site of in the lesions where the lesions are distal to the site of insonation, we typically get the high resistive waveforms which have high pulsatility index, and also there could be flow diversions. So flow diversions means, how do we identify flow diversions? If we had insonated this patient on for the opposite vessel, for the opposite MCA, if we had found that the PI is higher, or let's say there is a compensatory increase in the flows through the other circulation, that's what is called as a flow diversion. When there is a significant hemodynamic stenosis, there are increase in the collaterals or the pathways other than that specific segment. This is what is called as flow diversions, which can be identified with the help of transcranial Doppler. So this is the patterns which we get in case of lesions, if at all they are present distal to the site of insonation. So the final step is step 3.3, that is the pulsatility index, one of the most important index which we need to remember. So the PI as a rule of thumb indicates resistance distal to the site of lesion. So if at all we saw that if at all the lesion is proximal, we get a low resistive waveform, or the pulsatility index will be low. So the pulsatility index is altered, or it depends on how the vascular bed is distal to the site of insonation. And we all know the formula is the peak velocity minus the diastolic velocity divided by the mean flow velocity. So this is again, the pulsatility index can differ between the anterior and the posterior circulation. So this I am insonating between 4 to 5, that is 40 to 60 mm. This is probably the ipsilateral, this is ipsilateral MCA along with a deep middle cerebral vein. Here we can see there is a rapid upstroke, there is a stepwise deceleration, and there is a robust diastole, and the step of deceleration is very uniform. There is no point which is very fluctuant or very labile. Whereas in this is a normal PCA or a P2 insonation. We can see here, which is going away from the probe. Here there is a rapid upstroke, but the drop down is very steep as compared to this anterior circulation. This was in the same patient and it was a normal patient. So the high resistive waveforms can even be normally present in the posterior circulation. This point we need to remember in comparison with the anterior circulation. So the standard of comparison for the posterior vessels is always ipsilateral and contralateral, and it is not anterior circulation and the posterior circulation. So these are the conditions where we get high PI, the high resistive pattern, the stenosis, increased ICP, fever as we age, and there is increasing atherosclerosis, posterior fossa in comparison to the anterior fossa as we showed, and hypovolemia, aortic regurgitations, and elevate or any congestive states along with pulmonary hypertension can lead to high pulsatility index in the cerebral waveforms. Low pulsatility index, again complementary to the high PI patterns, are seen in hypercarbia, hyperemia, vasospastic states, anemia, poststenotic dilatation, loss of autoregulation. If there is an arteriovenous malformation, because there is a shunting of the vascular bed and the vessels directly go into the venous system, and in mechanical circulatory support devices, where it's especially in case of VA ECMO, where we see a non-pulsatile low that is non-pulsatile to low pulsatile cerebral waveforms. So PI can also be altered with depending on the inotropes we use, because there are certain vasopressor or inotropic agents which are neurotropic. There is a whole debate which is ongoing, especially with respect to testing autoregulation with the help of a transcranial Doppler pattern. So there could be inotropic or vasopressors which could alter the PI. LV dysfunction definitely alters, it increases the PI. RV dysfunction, LV and RV biventricular dysfunction also alters, along with ARDS also is known to alter the PI. And any sort of stenotic lesions, that is AR, AS, dynamic LVOT obstruction, which is more relevant in the critical care settings, can increase the PIR, can alter the PI to be more specific. Yeah. So once we know about PI, the main utility of PI is in the estimation of the ICP. So with the help of a PI, how do we estimate the ICP? There are three ways. That is the non-invasive ICP based, PI based formulas, non-invasive CPP based formulas, and the model based formulas. The most commonly used formulas are the Bellner's formula and the Koznikas formula. The Bellner's formula goes as ICP equals 10.93 times the PI minus 1.28. This is a conversion of pulsatility index into direct ICP, whereas the Koznikas formula is we estimate the cerebral perfusion pressure, that is the diastolic flow velocity divided by the mean flow velocity times the mean arterial pressure multiplied by mean arterial pressure plus 14. Once we obtain the CPP, we we subtract the mean arterial pressure. So the CPP minus mean arterial pressure gives the ICP. So these are two ways by which, these are the two formulas which we need to sort of know it by heart uh, to sort of translate our PI values into bedside non-invasive ICPs. There are various other formulas. So two most commonly we need to remember these two things. So these are the this is the relationship between the PI, ICP, cerebral perfusion pressure, and the arterial blood pressure. So what we need to remember is increase in PI is not always specific for increasing ICP, but also a drop in the cerebral perfusion pressure can lead to increase in the PI. So hence, just increasing PI doesn't imply raised ICP. Increasing PI with low diastolic velocity, what implies raised ICP. Low diastolic flow velocity is what indicates raised ICP. This was again reiterated in the latest Brussels consensus conference, which we had discussed in the last discussion, where they listed 7 variables, and out of which, if at all 2 are present, it means that there is a raised ICP. The third point being the PI more than 1.3 and along coupled with the diastolic velocity less than 20 centimeters is what indicates raised ICP rather than PI alone. So that's what we need to remember. So can we identify and characterize this vessel? So most of the things going forward from here is all images. So yeah. Can we identify the window, vessels, and
Transtemporal window.
yeah. So this is the transtemporal window. We are insonating ipsilateral MCA. The peak velocities is 95. The end diastolic velocity is 25.5. There is definitely high PI. So we can see a rapid upstroke, whereas the stepwise deceleration is not there. There is a rapid downstroke, and there is lot of aberrations in the stepwise deceleration. This is probably a high resistive waveform, which if we calculate PI, definitely comes above 1.3. Okay, so this is again today's image which we had taken. Window waveform analysis. Can anyone do?
Transtemporal window, ipsilateral MCA.
Yeah.
Upstroke is like upstroke, good upstroke, but the step
Upstroke is
down
very
pattern is
rapid.
not there.
Yeah, so the peak systolic velocities is very high. We can see here the drop down is so rapid, and even there is a systolic sort of a bounce back. 1/3. This is probably, if you consider this as systole, the systolic, the end of systole is really nearly reaching the baseline. This is not a normal waveform according to what characters which we defined as our normal waveform. And there is again a sort of a systolic bounce back, and the diastole ensues here. And to note here, the diastolic velocity is 18.3. So there is a high PI with low diastolic velocity. This definitely confirms raised ICP. Whereas in the previous image, there is definitely high PI, but the end diastolic velocity is still about 25. I mean, about 20. So as per the Brussels criteria, or let's say Brussels, the B iconic consensus, so it doesn't qualify as ICP. So to qualify as ICP, we need to have both elevated PI along with low EDV, end diastolic velocity. So 65-year-old diabetic hypertension presented with malignant MCA with hemorrhagic transformation underwent decompression, persistent poor GCS. What are the findings on TCD? Anyone can tell apart from Bharatesh? So this is the midline. Let's say, one sec. I'll go this. If we take this as the midline, so this is one half and this is another half. What can we appreciate here? So anyone else want to try?
Midline shift, sir.
Yeah, definitely midline shift is there. Here we can see on the half towards G, let's say towards the upper part of the screen, the video just sort of, comes and goes. Whereas this part or the lower part, even though it is sort of coming and going, there is no one point where there is no absence of an image. So this could be a videographic representation of high pulsatility index. In a brain death or a cerebral circulatory arrest scenario, this is what is called as a lighthouse sign. It comes and goes. So this is what is called as a lighthouse sign. We can see this here, and it's more consistent here. So when we insonate it through the same window, the ipsilateral one showed a peak systolic velocity of 61, end diastolic velocity of 12.2, and the PI of 1.71. Whereas on the contralateral through the same window where we insonated, where the pulsatility or the blinking nature were way lesser, the peak systolic velocity is 150 and the end diastolic was much higher, 48, and the PI was much lower. So can anyone interpret this? This is the same image as this. This is what we have insonated. And these are the values which we have obtained. Can anyone tell the conclusion of this? Or let's say, what does this mean?
A lesion is at the MCA, ipsilateral MCA.
Okay, and so we are talking. Fine, we are talking. It could be that the obviously patient had a malignant MCA and underwent decompression had already given in the scenario. So TCD is a see when we do a CT, it just sort of gives us an estimate of, let's say, a global perfusion crisis or a global raise in the pressures, whereas TCD gives us even the local changes in the hemodynamics and the local changes in the pressure. So if we can see here on the side of the decompression, the pulsatility index is 1.71, whereas on the contralateral side, the PI is 1.23 and the end-diastolic velocity is maintained. So the differential pressures in the ICP, or let's say in the cranial compartment, can also be identified. That was the significance of this TCD waveform. And also, as we can see here, the opposite MCA is flowing at a much higher rate. That's what I was telling. If at all there is a lesion distal to the, let's say, if the lesion is so severe, this leads to what is called as a collateralization. So the opposite MCA velocity, the peak velocity is 150 compared to 61. So possibly it is trying to sort of collateralize from the other side, and the pressures are much higher on the left hand side of the screen. So this is an image depicting the regional alterations, or let's say regional variations in the ICPs with the help of TCD, which is its own speciality uh, of analyzing TCD waveforms and indices and velocities. So this was again the same patient's CT, which showed, ipsilaterally it was completely destroyed, whereas contralaterally we did see some sort of graphite differentiation being maintained. So can we, along with the same patterns going forward, can we comment about these patterns? Anyone else?
These are diastolic.
Yeah.
These are diastolic reversal is there. We can see that diastolic velocities have reversed.
Yeah. So the left hand side of the screen and the right hand side of the screen. So are the left and the right hand side both the same? I mean, so one more interesting part is on the left hand side of the screen here, at the depth of 5 centimeters, we are finding a blue trace. Can we see that?
Yeah.
Is it normal? I mean, what could be the possible explanation for this?
No, we usually see, as you told, that lighthouse sign. So
Yeah.
whenever there is a high ICP, so
Yeah.
you would be seeing that alternate red and
Exactly. So
blue
possibly the
pattern.
image was just captured, or let's say I just froze the image during the. So it is MCA. So we should not just go by the implication of this. Is we should not just go by the color of the vessel. So if we had just gone by the color of the vessel, this we would have taken it as ACA. So always going by the depth at 5 centimeters is very essential to identify this, and it was probably frozen image at a point in the diastole. So this is definitely, there is a rapid upstroke, but there is the diastole and the stepwise decelerating patterns are grossly altered. It is a high resistive waveforms. Here we can see in the left hand side of the image there are some traces where there are diastolic flows which are coming in, whereas here also in one of the cardiac cycle we see one such image. So this patient eventually, from left hand side to right hand side, it progressed over a period of time, and this was more sine qua non of a brain death sort of scenario where the peak velocities were less than 50. That's again part of cerebral circulatory arrest, when probably Mohan or one of us could be discussing further. So this is high resistive waveform again. Second, we'll go to the next image. So this was again the same thing. As the resistance or the ICP increases, we move from a normal waveform of a rapid upstroke and a robust diastole waveform to a place of to a high resistive waveform where there is some diastolic velocity, there is absent diastolic velocity, to reversal and finally a no flow state. This is where we end up in no, I mean cerebral circulatory arrest, or complete absence of a flow. So A and B can be sort of, I think we had already had this. So it is in the same image. There is A, it is a bifurcation insonation at somewhere at the depth of between 5 to 6 centimeters. This is an MCA and the ACA in the same trace, whereas this is a MCA with a possibly a middle cerebral vein here. And again, what is the difference between these two? These are the same patient. Can we identify difference between the left image and the right image? The waveform analysis per se. What is the difference which we can note here?
Image A is P1, ipsilateral P1 segment, sir.
Yeah, ipsilateral P1, yeah.
And image 2 is ipsilateral MCA segment.
Yeah, that's fine. So the waveform identification is done. It is a transtemporal window. What are the waveforms indicating? Is it normal, abnormal? What is it? So the velocities
Low
probably,
acceleration.
so the velocities are in sort of, cutoffs with the normal velocities, which the slide which I had earlier put off. So the thing which we need to note is the difference between the anterior circulation traces and the posterior circulation traces. That's the whole reason why the reason why I put up this window. And what is seen, this is probably something very basic. So this is a transtemporal window. We can see the third ventricle. So vessel in red from the PCA. This is the PCA. Can we identify this vessel which is coming, which sort of mimics uh, you know MCA? Any comments about this? Anyone
Choroidal
else?
vessels.
Yeah. So possibly choroidal vessels. Yeah. So why I'm putting up very frequently is because this can be sort of mistaken to MCA. MCA is going here along the sphenoid ridge, whereas this is shooting off from the PCA. So we need to identify and differentiate what is a MCA and what is a PCA, what is a choroidal vessels. Okay. So identify the vessel and the view. Which is this view?
Suboccipital view, sir.
Yeah, suboccipital view. So I am insonating.
Basilar, right?
Yeah. Probably at the start of basilar. So here, as we can see, a little bit higher PI than other anterocirculating vessels. So this was also again a suboccipital view. This I am insonating. What is this? Probably there. It is a tilt, but what we need to identify is the view. Here we can see the basilar. This is the vertebral. What is the vessel which is shooting off like that? It is the pica. So the posterior inferior cerebellar. This is the waveform of the pica. If we practice, we definitely can insonate these things. What is this vessel? I'm insonating at a depth of 8 to 9 centimeters. Transtemporal window. The vessel is going away.
Contralateral A1, sir. Sorry. Contralateral A2.
No, it is in the plane of A. It is in the plane of A. So this is A1 probably, contralateral A1. This is, the depth is not correlating with the ipsilateral A1 because we need to get a depth ipsilateral A1 at 60 to 70, right? So it is beyond 8 centimeters. So it is contralateral ICA. Okay. So identify the vessels and comment about the waveforms. What are we insonating? The left-hand side of the image, it is at a depth of 50 to 60 centimeters. Here we can see possibly, A1, MCA. What is this vessel?
So first image is ipsilateral P1 segment.
Yeah. This is, here we can see the midbrain, right hand side of the image. So something is winding around that. It is P2, right?
P2, I said P2.
Yeah. So what are the differences which you can note here? P1 has a peak systolic velocity of 39, whereas P2 has a peak systolic velocity of 58. So what could be the implication? Can P1, or let's say, can P2 be higher than P1? I mean, let's say if at all it's not, this was a patient, around 30, 34-year-old. So if there is no stenosis between what could be the possible differential diagnosis where P2 velocities are higher than P1 velocities? Anyone? What could be the possible reasons of P2 velocities being higher than P1 velocities? We have insonated P1, we have insonated P2.
Aneurysmal dilatation.
Aneurysmal dilatations, yeah. I mean, it should not rise the velocities, P1 has 39, whereas P2 has 58. One thing is there is a stenosis between the P1 and P2. That is, as per the Spencer-Reid curve, it is somewhere between 60 to 80. That could be one differential diagnosis. Or other physiological diagnosis could be?
Collaterals.
Yeah, what collaterals? This is a fetal PCA, okay? So if at all there is a poster communicating which is got patent, so 30% of the times fetal PCA, PCOMs can be normally also present, which is called as a fetal PCA. Here, this was one such patient where P1 was lesser than P2, no, P2 was higher than P1, and this could be possibly a persistent fetal PCA. Any other comments about this? Okay, we'll go to the next one. Identify the vessels and spot the difference. This, I think we had a discussion. This is a transtemporal ipsilateral. This is again a bifurcation insonation representing MCA and ACA, whereas this is MCA and the middle cerebral vein. So with such waveform analysis, depth, the pulsatility indices, what are the indications? Or let's say, why do we, or where do we specifically do, there can be neurological indications or systemic indications. Neurological indications being the non-invasive ICP and CPP estimation. We did see the Bellner's and the Korsakis formula. Monitoring cerebral order regulation, this is a whole new domain by itself. Sickle cell disease, differentiating stenosis and hyperemia. Ischemic strokes, there is something called a STIBI and Kojif grades, which is very important post thrombolysis and post mechanical thrombectomy. Post mechanical thrombectomy, I had put up an image where we did see M1 had higher velocities, M2 had lower velocities. It was Kojif 3. Microembolus or shunt detection, if at all there is a stroke of an unknown uncertain etiology, to detect the shunts or the RLS, the right to left shunts, we do have take an help of TCD and identify what is called as a high intensity transient signals. Hydrocephalus, possibly deciding on the insertion of EVD, or let's say weaning off from EVD. How do we clamp EVD? All those things can be decided based on the TCDs. Stenosis and endarterectomy patients, or which patient needs to undergo, or where we don't disturb the collaterals, can also be a sort of an indication to do a TCD. And AV malformations, because there would be a low, let's say, another reason or a differential diagnosis for this image could have been this image, one sec. Yeah, this image could have been a AV malformation where the pulsatility index will be lesser, more because of the shunting of the distal resistance vessels and directly into the vein. So AV malformations can also be sort of a soft indication to diagnose TCD. Of course, the gold standard remains the DSA. Again, systemic indications. There are various things. Any encephalopathies, evaluation of the cardiac shunts, post-cardiac arrest monitoring. There is a classical triphasic response which is described in the post-cardiac arrest settings. There is an ongoing trial where they have tried to sort of achieve a peak velocities of 60 to 70. I think if I don't if I am not mistaken, in the post 24 hours post cardiac arrest, they have tried to sort of maintain that using a transcranial Doppler to then they are trying to achieve good CPCs, cerebral performance categories, and autoregulation status can also be identified, and monitoring cerebral hemodynamics in the mechanical circulatory support devices. So to do all these things, the first and the foremost step is we need to do what is called as a basic complete insonation. What is the things which comes under complete insonation? Identification. So let's say, to identify all these vessels, we need two windows, that is transtemporal and the suboccipital. So these vessels have to be identified along with different parts of them. The ACA, ICA, MCA, PCA, and the vertebral basilar. These are a must to be insonated. This is how we insonate. This was done by my colleague Dr. Bharatesh, and we, as I scanned the patient, this is how possibly we can note it down and try to identify. So if we start off with this way, try to retrospectively correlate with the imaging or the DSA findings, probably we do achieve some point. This was from another patient where he had some sort of a stenosis and variability. So I would recommend every one of us to sort of make a picture like this and do a complete insonation of at least one patient the next week or so. So what's not a part of basic insonation? Orbital window, definitely not. Venous insonation, definitely not. Submandibular window, definitely not. There are specific instances where we use submandibular window, and frontal windows also are very rarely used. Hardly it gives us any information. And yeah, it is never the tool that decides. It's the hand and the heart of the one who wields it which decides the outcomes. So the tool being the TCD, the hands being the skill of acquisition of an image, and the heart being the analysis of the waveforms which we did today. Thank you. If anyone is interested, can join our group and sort of contribute and put up the images which you scan at your place. If at all anyone has any questions, feel free to ask. If not, sign out. We'll do that. Anything else, Mohan?
Yeah.
I think, and Dr. Mohan would be doing, probably he told he would be, doing subarachnoid hemorrhage and various other things and TCD implications of the same. Am I correct, Mohan?
Yeah. Yes.
Yeah, sometime you could put up the schedule. So yeah, this is where we are. Anything?
Sir, I have just few things to emphasize. I mean, overall a wonderful presentation, like where we have touched almost everything, so that we know, what waveforms we are getting, how do we interpret and all. What I do in my practice is that once I want to see any TCD, first I'll note down hemodynamics, because at what hemodynamics we are getting these velocities, it should be known. We need to correlate, number one. Number two, if I have to see one parameter which is most important, I feel, is PCO2. So I remember, like, I got one of my traumatic brain injury patients somewhere at around 2 o'clock in the midnight. So as soon as the patient has come, me and my colleague, where we are doing the point of care ultrasound, nursing officer, they are trying to stabilize or take the hand or something like that. So at that point of time, when I've done transcranial Doppler, the first two velocities which have come, it was showing a higher peak systolic velocities, higher mean flow velocities. I was wondering, because traumatic brain injury is there and there could be a hyperemia. But the nursing officer who has collected the ABG, she has come with the result saying that PCO2 is 70. So I'll put that slide in the group. So it was 70, and then we started, ventilating the patient appropriately, and then after maybe 1.5 hours, the velocities have come down. So PCO2 has a very good influence, and we need to just keep this in mind. And So this is PCO2, and then as you said, like a basic complete information is required. Then interpret as per the clinical situation, and we tend to do mistakes, beginner mistakes. So this is the right forum for us to actually share our TCD images. We can discuss, and then we can come to a correct conclusion. So
Exactly.
that's
So
all from my side.
yeah. So Dr. Mohan summarized it, beautifully, and the most important point which he highlighted is the systemic hemodynamics. So it is a very important thing because, as we saw here, definitely whatever the images which we interpret has to be always, uh, taken into account with the systemic hemodynamics being sort of respected and being valued for their numbers also. Because, and other part, as you was telling, there are various things which can alter the waveforms. So possibly if we remember the high pi and the low pi reasons, possibly the waveform alterations can also be sort of remembered upon. This could be one thing which we can sort of remember. And as he was telling, the hypercarbia, the carbon dioxide, which is one of the things which is used for vasoreactivity testing, or one of the autoregulation components. So carbon dioxide and anemia, all these things can alter the waveform patterns. So anything else, Bharatesh?
Hi, sir.
Yeah, anything else anyone wants to tell?
Yes, sir. I have one doubt.
Yeah.
Sir, can you please put up the PA slide? Pulsatile index.
One second. This one?
That low and high PA. Yeah. If we see here, hypercarbia, hyperemia, post-stenotic insulation, everything is like vasodilated state.
Yes.
Where we have a low PA, but why this low PA is in vasospasm also?
So yeah, vasospasm is one such scenario where we get a low PI. So that is that specifically I wanted to mention that vasospasm. That is why we identify the velocities, and that's the reason also why we sort of do a Lindegard ratio for anticirculation, and there are various other ratios which are defined. So in vasospasm, low PI is what I'll put up this one sec. This image where I put up, this was actually this one turbulent flow which I put up. So this patient had a MC aneurysm. Okay, patient was coiled. Actually, the turbulence which we are getting here is possibly the turbulence secondary to the coil. With it was all retrospective thinking, or it could have been due to the flow mediated hyperemia mediated reduction, hyperemia mediated stenotic phenomena. If we can see here, the mean flow velocities are TAMAX is 155. That is somewhere coming into mild to moderate category. But if we see here, the pulsatility index is 0.63. So pulsatility index is is low in vasospasms, and hence it has to be standardized with the systemic, or let's say an extra or internal carotid through a submandibular view. That's when we can sort of differentiate. That is why it is differentiated between hyperemia and vasospasm with the help of the index. So exact reason may be difficult to explain, but vasospasm definitely has a low PI, and that's the reason why we use the Lindegard ratio. And I did show you the image also where the patient had vasospasm, but the PI was low. Anything else? Any other reason?
Yeah, so actually, what happens with vasospasm is, so it's basically a focal narrowing, and with that focal narrowing, all velocities increase. So if we see the pulsatility index formula, so it is basically peak systolic minus end diastolic by mean flow velocity. So what happens is all the velocities increase, so you don't see a kind of increased pulsatility index. So for pulsatility index to be increased, it will be like PSV minus end diastolic velocity. So your end diastolic velocity should be decreased, and that is when the numerator increases, and your pulsatility index can be high. But in vasospasm, because there is a narrowing which is focal, so we get to see all velocities increased, PSV, end diastolic, mean for velocities. So overall, the ratio remains same or comparatively less. That is the most probable explanation for
Possible
why
explanation. Could be.
for why PI is less than the vasospasm.
Okay,
But,
sir. Thank you, sir. Thank you so much.
Yeah. Okay, fine. Then I think if everything is done, possibly we can sign out. Okay. If at all any further things by Dr. Mohan subsequently, he would put up on the group. Anything else Nishal or anyone else wants to add? Okay, fine. Thank you. Thank you, guys. Have a good night. If anything else which you sort of insinuate, or let's say something interesting which you sort of visualize during your routine practice, please do share so that we can have a learning point each day. That way. Thank you. If you find any materials also, please do share apart from whatever I've said.
Yeah. Sure.
Thank you, guys.
Thank you, sir.
Thank you.
Thanks.